We're going to go back to more on the local regional level, and we're going to hear from our Disaster Medical Coordination Center coordinators. We do have two of them in the room here today. Mark Sheldon had a commitment. Our Disaster Medical Coordination Center roles are split up in a sub-regional model so that Holy Family Hospital serves the northern hospitals in our region in Ferry, Stevens, and Pend Oreille counties. Deconess Hospital not only serves the central counties for disaster medical coordination, but they also serve as the lead regional role. So they have the bigger role of overseeing the region if they're ever called into that role. Pullman Regional, Bill Whitman is here, serves the southern part of our region, the counties down south of Pullman. So that makes a lot of sense. So that's just kind of the hierarchy of how the system is set up, so that as they're talking about their work, you get that feeling. The other piece that we don't that is not in that is, as Erika mentioned, is we also have a statewide DMCC process, and Providence Sacred Heart Hospital is built into that level on a statewide activation level. So if there was ever a statewide event that was multi-regional, Sacred Heart Hospital or Harborview would work jointly or separately depending on the incident. They kind of serve as a backup to each other, support of each other, but make sure we've got one or the other that are functional on a statewide level. So it's quite an elaborate system that's been put together. And what we're going to hear from next is from Erika from Deconess. And she's going to give us, and I think Bill's got some information he's going to share with us, kind of update you on that process, where we're at, what we've learned, and where we're going. So you can just hit that button.
Hi, I am Erika Abdnor. I'm the Director of Clinical Operations for Deconess Hospital. I've been at Deconess for 16 years, but have only been involved in the Disaster Medical Coordination Center for a short time. The way that I became involved was that as I moved up and took this role, one of the groups that I oversaw was our administrative or house supervisors, and they were involved. They are part of DMCC activation and part of that whole operational process. So I became involved in that manner. I became more extensively involved in 2016 when we were exercising and drilling. You know, as I reported at the statewide DMCC meeting, it was very evident in 2016 for me participating and observing, and I know for external agencies such as our other area hospitals, EMS, the Combined Communication Center, the Healthcare Coalition, anybody who observed or participated saw that DMCC operations was totally ineffective. It just was not working. So as Ed had said, our job is to help facilitate patient placement from a disaster or MCI or even an evacuation to the facility most appropriate to care for them in a timely and efficient manner, but also importantly in an attempt to minimize secondary transfers. One of the things that I wanted to bring up was why it wasn't successful. I deal a lot with operations, and I think any operation that you take on, you need these items for it to be successful. The first is a defined operational process. That is one thing that it was very clear that the Disaster Medical Coordination Center did not have. Every exercise was ran differently. It was just a mess, and it just wasn't successful. Effective communication, that was probably, I would say, our biggest problem. It's funny to look back at the exercises we've done in 2017 and look at the after action reviews and look back in January and February. Back at that time, we weren't even using WATRAC as a communication tool, and that's something we just started doing this year. WATRAC is phenomenal. It has really enhanced our communication. Measures to evaluate success. We developed, you know, as Ed had talked about, roles and responsibilities and the DMCC concept of operations, just so that we could measure our success and determine whether or not we were meeting the needs of our community and our region. And like I said, with the after action reviews, consistent reevaluation of operations for continuous process improvement. So our initial actions for improvement, and this isn't just Deconess as a DMCC, this was a regional effort that included, like I said, Combined Communication Center, the Healthcare Coalition, especially a lot of help from Ed and Travis, and EMS and our other local area hospitals. The DMCC concept of operations was developed, and that basically defines the function and purpose. What that really means is that that is the process of DMCC from activation to deactivation. The DMCC roles and responsibilities, which defines the annual expectations of the DMCC. It's quite a list of expectations, but what it really does is it allows for accountability for those of us serving in that role. The DMCC MCI workflow, which I have a picture of that I will show you next, which is basically predetermined patient placement numbers. Deconess Hospital invited the area hospital ED directors so that we could get together and to put on a graph at any given time, how many patients can you take? And let me go to that slide just so that I can show you. Now, please know this is not something that we developed. It's something we did adopt. We saw it and thought it was a great tool. Like I said, we got together. The purpose of this is because prior to the DMCC concept of operations, we weren't utilizing this tool. So what would happen? The Disaster Medical Coordination Center would be activated, and patients would just sit there on the scene waiting for the DMCC to get stood up, waiting for us to gather information from all the hospitals with respect to their patient receiving capabilities, and it really resulted in delayed patient movement, which is never good in any situation. So we did adopt this tool and talked with all the hospitals. The Combined Communication Center does have a copy of this tool, and what it allows them to do is to begin patient placement and patient movement while the DMCC gets stood up. As you can see on the left, it also shows our whole DMCC operational process too. I'm going to show you the next slide too, because there was an additional thing that we did. We also reached out to other hospitals in our region to determine what they could take should we need to look at a regional response and need to utilize those hospitals. Uh-oh. No. Okay, we're back. The purpose of our exercises for 2017, we have done 7 exercises since January 1st of 2017. The purpose of these exercises was basically to raise awareness and educate all the primary agencies, evaluate our operational effectiveness, evaluate our communication, but we also really wanted to evaluate the Disaster Medical Coordination Center concept of operations that was developed, the roles and responsibilities, and the use of that MCI workflow that you just saw. I'm not going to go in real detail about these. I did when I first put this slide together, and it would have been a very, very long presentation, you know, going into what worked well and what didn't work well, because there was a lot that didn't work well. But what I will say about these exercises is that after every one of these exercises, we got together kind of as the DMCC stakeholders group, which included Ed and Travis, and members of the Combined Communication Center and members of area hospitals, and I should put that Kootenai also participated with us on this. But at every after action review, we were able to look at, okay, what didn't work well, and we made sure to improve that and fix it for the next exercise. So really these exercises were about continuous process improvement throughout the whole year. The first 3 exercises, you know, we just did a charter bus crash. In April, we decided to change it up a little bit. In June, the Disaster Medical Coordination Center kind of attempted to jump onto an exercise that Fairchild was doing, which we jumped on pretty late. It didn't go so well. The DMCC wasn't utilized. But one thing that I can say that was positive is that's the first time that I felt that we as local hospitals and as the DMCC were actually prepared. And then in June and July, we just did incident advisories just to practice our communication surrounding Hoop Fest and Sky Fest. You know, as we know, mass gathering events have the potential to, you know, have an incident. And so we sent out an incident advisory and established a chat room in the command center just so that we could all communicate. I also wanted to let you know about things we have done internally in the DMCC in Deconess. We actually established a DMCC room. June was when that was finished and the first time we actually used it. So it has all of the necessary equipment. It's got, you know, a computer, a whiteboard, We have an internal phone line. We actually also have an external phone line in case there's power problems. We also have a direct line to the Combined Communication Center. I also have a DMCC binder down there, which contains all of the forms and paperwork we need to operationalize the DMCC. As for the administrative supervisors, they are on 24/7, so they are the ones who are going to be first notified, and I need them as a team, to start getting DMCC stood up and activated. As of this week, they have all completed their WATRAC training. They've had DMCC education. Another thing that I developed for them was a job action sheet that I'm getting laminated this week, and they will carry that with them. And it basically lets them know what their roles and responsibilities are should they get that call that they need to activate, a step-by-step process. With respect to the emergency department, I developed a clipboard that is kept by their HEAR radio. On the very front of that is their own job action sheet, because I want everybody in the emergency department to know when they get that call that there is an MCI disaster evacuation. I want them to know exactly what to do. Part of the problem in the past is people have called to activate. The emergency department just said, okay, thanks, goodbye. And nothing was done after that. So they know what to do now. So they have a job action sheet. They also have an alert call data sheet that they know if they get that call, they are to take down information on the incident, type of incident, estimated number of patients, triage level, and a good contact number. And then they also have their HEAR call, the roll call sheet for all the hospitals. I actually just revised that last week, but it is kept on there. That's so that they can go on over the HEAR radio, let people know what's going on, and do a roll call with the hospitals. What I realized after the Freeman shooting is I realized that it only gave the option of saying this is a disaster. So I did change that so that they have the option of saying this is a disaster, a mass casualty incident, or an evacuation. So we did revise that. Here. So next calendar year, and I don't need to go through all of these. I have like big dreams since I got involved in this, and I really am, in all honesty, looking far down the road at where we should be. We're definitely a lot further than we were a year ago, but we do have a ways to go. We are responsible for doing 6 DMCC exercises a year, which we will continue to do that. I know that there's a lot of work going on for training for Region 9 hospitals and pre-hospital agencies, but I would also like to do some teamwork with our sub-regional DMCCs. This past, probably I'd say 15 months, there's been a lot of focus just on Deconess as the lead DMCC, so I would like to make sure that we're just working together, with Pullman and Holy Family. I would like to reach out to the remaining DMCC or the remaining hospitals to complete that MCI workflow. I'm also planning monthly refreshers for my internal DMCC team. You can learn WATRAC training, you can learn a bunch of stuff, but if you don't use it, when it comes time and you need it, you're going to forget. So we're going to do regular, just internal exercises with my group. Another part of our responsibility is to reevaluate, update, and hardwire the DMCC concept of operations. Some things that I would like to look at, is just to reevaluate the triggers for activation and for incident advisories. Define the handoff between the Combined Communication Center and the Disaster Medical Coordination Center, and evaluate, we did set certain timing parameters from the time we were notified till the time we stood up. So I would just like to reevaluate those, because I have, timed those a little bit, and I think that those need to be reevaluated. And definitely establish defined metrics for measurement of success, so that when I come back next year and present this, I can actually have metrics where we have timed things to make sure that we are meeting the needs of the region. And longer down the road, I would like to make sure that we're exercising on all shifts so that we capture participation from all staff and all hospitals, and maybe change it up, do a variety in exercises scenarios for greater preparedness. I will have to admit, with the Freeman shooting, that one actually, when I sat down at my desk, 4 or 5 hours later after we deactivated, it really concerned me, because I thought, this was 3 pediatric patients, which was very manageable. But I thought to myself, what if it had been 30? Then what had we done? So I think we need to look at exercising different scenarios, and get to a point where we're doing exercises that include the entire region. So anyways, that's my year-end review. Does anybody have any questions?